And maybe the main goal is to enlarge our research network, so I'm hoping on that. To talk about that, first of all, so the structure of the research in the Netherlands, I'm going to talk to you about the Dutch Research Consortium, how it started and how we are, where we are now. And then I will talk to you about the tasks of the research nurse or research midwife. And then I will explain to you what the completed study were up to now in early pregnancy and the ongoing studies. Well, the Dutch Research Consortium started in the late 90s because 5 years in a row there was some funding available for obstetric studies. And then 5 gynecologists who knew each other, who were working in different hospitals, decided that they had to work together to do these large research studies. And then they knew they had to do multi-center studies, so they needed each other. This wasn't a formal network, but well, we call it like an old boys network. People know each other, and then they will give each other favors. The one works in the study of the one, and then the other one will do the favor back. And then it grew into, well, you see it there, a young girls network. This is so the group became a lot bigger. And these are only the research nurses and research midwives and the young doctors, researchers. So the group is even bigger than that. And the one organizing it was Ben Willemol. So I enlarged his picture there because he's hiding here at the back. So this was in 2012, how it grew. And there I'm calling it Research Consortium 1.0 because at the beginning of this year it changed it to what we call now Consortium 2.0, where the Dutch Society of Obstetrics and Gynecology, the NVOG, decided that it had to become part of the NVOG. And the aim of that was actually to commit all the gynecologists, because all the gynecologists in the Netherlands are members of that society. And this was not only to commit them, but also to make them enthusiasts for all those studies. So through being professionals, they had to be part of those studies. And what's coming up now, but we're not there yet, but it's being explored, is a role for health insurances, because it might be happening that health insurances will only reimburse treatments when being part of a study, if the study is being done on that treatment. So that would mean a big change, but we're not there yet, we're just talking about it. This is what it looks like now, the Consortium 2.0, where you have, here you have the NVOG, and here the Research Consortium. And when you start at the Science Committee will find where the knowledge gaps are, and then feed the consortium with trials. So then the trials are done by the consortium, and then the consortium feeds the results to the NVOG again, where the Guidelines Committee can adapt the guidelines. And then from those guidelines, there come new knowledge gaps, and then they go back to the Science Committee, and then the circle is round, and then we'll continue that circle until we know everything, which will probably take a while. The consortium in the Netherlands is organized with clusters, and here you see a map of the Netherlands, and you see that all the whole of the Netherlands is covered by the clusters. So those are the large circles, and the red dot in the middle is where the head of the cluster is and where it's being organized. And those clusters meet all together a couple of times a year. So on the phone they meet once a month, and then 4 times a year they will meet in person. And then they discuss the ongoing studies, see if the inclusions are going well. Maybe sometimes some hospitals will have troubles including patients in studies, and then other hospitals will be able to give them ideas and tips about including patients. And data collection, data management is discussed, and then the upcoming studies, so that the hospitals are well prepared for the studies that are coming. And the research nurse in all that, well, the research nurse, we have a couple of them in each cluster. And to be a research nurse in the Netherlands, you first have to have a 2-year training, and then you can call yourself a research nurse or research midwife. So it's someone that's first a nurse or midwife and then follows that training. And the research nurse has a task with patients. So she will, in the patient care, she will inform patients about studies and then try to counsel them and then to counsel them into studies and randomize them if they agree. She also has a task with protocols, so she will review protocols, make sure they can be implemented in the hospitals, and then she will inform all the staff about the study protocols, so the nurses, the doctors, the one who see the patient, and who might pick out the ones that are that can be included into studies. Then she goes into the hospitals within the cluster and inform other hospitals, and then gets the permission from the other hospitals to start the study, and when the studies are running, she will go there and make sure that the data collection is going and the site files are there for all the studies. And then she participates in the meetings that I told to you about before. If you look at the cluster of Amsterdam, Amsterdam is the hospital where, the EMC is the hospital where I work, and we have also another university hospital. So the cluster of Amsterdam has those 2 university hospitals and 16 other hospitals. And there's one cluster coordinator who is a gynecologist, and we have 9 research nurses and research midwives. There the research nurse does some extra tasks within that cluster, which is research consultation, so actually seeing patients herself, and she also makes sure that all the patients who can be included into studies are included by informing all the doctors, and she really looks for referrals. So for example, in the care of recurrent miscarriage, this is an example of what the task of a research nurse can be. In this case, I took the example of the ALIVE-2 study. I will tell you a little bit more about that later, but the ALIVE-2 study randomizes patients who have inherited thrombophilia, in this case factor V Leiden, and they are randomized between giving heparin or standard antenatal care, and then they look at live birth rates. So these patients, when they're referred to the hospital, first of all, they will see a doctor, and that doctor has been very well informed by the research nurse about the study, so he will or she will immediately know this is a patient who might be included into the study. So the doctor refers the patient to the research nurse, and the research nurse will then, first of all, make sure this patient actually fits into the study, so collect all the needed data, and then she will inform the patients about the study, and then get an informed consent if they agree, and then randomize them, in this case for the ALIVE-2 study. And in the case of the ALIVE-2 study, one of the groups needs to have some medication, and they need to inject themselves, the women. So the nurse will make sure that the medication is available, and then she will give it to the patients and give all the instructions that are needed for use. And after that, she will make sure all the follow-up is done. So she will plan the next visits and make sure that all the data is collected during those visits. Well, this is what our local clinical workup looks like in recurrent miscarriage. And this is a little bit to show you how we make sure that all the patients that can be included into studies are actually informed about the studies. So these are the diagnostics first that we do in those patients. And then the next column are once you have the diagnosis, which treatment you do. And in red are written all the studies that are going on now. On each study I will tell you more later when I discuss the ongoing studies. So this is a tool that is used in our clinic to make sure that everyone is well informed about all the ongoing studies. Now I would like to tell you a little bit more about completed studies through the consortium, and I'll start with the ALIVE-2 study. the Life 2 study is later. The Life studies is a study that was done on women with unexplained recurrent miscarriages, and it was to see whether giving them utrogestan, giving them anticoagulants was giving them a better chance in the live birth rate. So they were randomized in 3 groups, heparin and aspirin, or aspirin alone, or placebo, and we looked at live birth rates. And the conclusion of that study was that it didn't matter whether you were giving them anticoagulants or a placebo. Then actually the ASAP study, I wanted to name it, but I know everyone is very well informed after the talk of Femke today. So you already know that when women have a tubal pregnancy and a healthy tube on the other side, for their fertility prospects, it doesn't matter whether you do a salpigotomy or a salpingectomy. Then the PROMISE study. The PROMISE study was done on women with unexplained recurrent miscarriage, and here we looked at giving them progesterone, so to see what effect it had on live birth rate. So they were randomized between given progesterone or a placebo. So utrogestan is progesterone. And we don't know the conclusion of that study yet, so we will probably have to wait until January, and we're all very excited. And now I move on to the ongoing studies in recurrent miscarriage. The T4Life study is a study in which we look at giving women with TPO antibodies and recurrent miscarriage, giving them levothyroxine. So they're randomized between giving levothyroxine or a placebo, and we look at live birth rates. Then the Alive 2 study is, this is the couple I was talking to you before with the factor V Leiden. These are women with inherited thrombophilia and recurrent miscarriage, and they're randomized between given heparin or standard antenatal care, and we look at live birth rates. And then the TRUST study. The TRUST study is a study in which we're not looking only at recurrent miscarriage, but also subfertility and women with a uterine septum. And those women are randomized between removing the septum or expectant management. And for this study, I would like to show you, so this is how they're randomized. One more thing about this study is, well, it started in 2009. This is the inclusion rate. And we needed 68 patients. And as you can see, we're now at 30 patients. And we were hoping actually to reach the 68 patient in 2012. So what we're thinking now is that maybe this is the work of the first consortium, and that from 2014, the Consortium 2.0 started, and then from there we were very fast reached the 68. So let's hope that that will work. Well, to conclude, well, a lot of work has been done, because first the consortium was started, and people realizing that working together was the only way to go to do these large trials. Then it moved up to Consortium 2.0, where the professionalism from the gynecologists is more used actually, and so the people are more stimulated probably. And you see that there are a lot of studies that have been done already, large studies, and there are ongoing studies that we're very excited about. But we think we're not there yet, so we're hoping that from the Consortium 2.0 it's already changed a lot, but we know that there's still a lot of work to be done. So now we're hoping to maybe enlarge the network through all the participants here, so please note my email address, and I will refer all the questions or interest in studies to the right persons.